Hello, and welcome to the CAP Today webinar for Tuesday, October 24th. I'm Bob McGonnagle, the publisher of CAP Today, and I'll be your host and moderate a question and answer session after our formal presentation. Today's webinar is entitled Diagnostic Stewardship in Acute Infectious Gastroenteritis. What can real-world data tell us? This webinar is made possible by a special educational grant from bioMérieux. We want to acknowledge bioMérieux and thank them for their essential support for this very important webinar today. Our single speaker today, and I'll say more about him in due course, is Dr. Ferric Fang of the University of Washington School of Medicine in Seattle. But before we begin, I'd like to go over just a few housekeeping tips that I think should make your experience of today's webinar more enjoyable. First, we often suggest that you go ahead and refresh your browser. Remember at all times that we have live help available to you throughout the course of today's webinar. You'll see a phone number in the lower right-hand corner of your screen, 858-345-5916. You can call that with any kind of technical problem that you have, whether it's with the platform or with the audio, and people will, in a very timely way, assist you and get you back and resolve your issues. Also, you'll see below the slide deck a Q&A box, and that Q&A box is, of course, really for your comments and questions for Dr. Fang, and we'll collate those, and I'll lead that session after he finishes. But you can also talk about any technical issues you have, and people will attend to those very, very quickly. We will indeed post all the slides and content of today's program online in about a week. I want you to know you will receive some emails as follow-up from ourselves or from bioMérieux, so be alert. Finally, I need to remind you, as always, that CAP Today does not endorse any products or services that may be mentioned in today's webinar. And of course, any remarks of mine are purely personal, not to be taken as policy of the CAP Today or the College of American Pathologists. And so with that, it's my great pleasure to invite Dr. Ferric Fang and welcome him. He's a professor of laboratory medicine, microbiology and medicine at the University of Washington School of Medicine. He trained at the Harvard Medical School, did his residency and fellowship at the University of California, San Diego. We worked together a while back, and it's a great pleasure to have him again to address this very important topic. And I will now ask Dr. Fang to begin his presentation. Dr. Fang.
Thanks so much, Bob. It's a great pleasure to be with all of you. In this presentation, I'm going to discuss acute infectious gastroenteritis, a common illness that I'm sure you've encountered and have very likely experienced yourself. I'm going to tell you about a recent large study showing that the method used to diagnose patients with acute gastroenteritis can have a significant impact on clinical outcomes and on healthcare costs. First, a disclosure, I'm a paid consultant for bioMérieux. To begin, I'd like to tell you about a patient who recently presented to the emergency department at my hospital, Harborview Medical Center in Seattle, Washington. This patient is a 27-year-old man who lives in Seattle. He came to us after a week of watery diarrhea and severe abdominal cramping that persisted. His social history is notable for intravenous heroin use and homelessness. On examination, his abdomen was found to be diffusely tender without rebound. An elevated white blood count of 13,000 was seen, and a stool sample was sent for multiplex PCR testing, which detected Shigella, or enteroinvasive E. coli, which is a kind of E. coli that carries the Shigella virulence plasmid, and it causes an illness identical to shigellosis. So I'd like you to keep this patient in mind, and we'll come back to discuss how he was treated after I tell you a little bit more about gastroenteritis. As I'm sure you all know, acute infectious gastroenteritis is a common infectious disease that affects both children and adults around the world. The typical symptoms of acute gastroenteritis are nausea, vomiting, diarrhea, and abdominal pain. And acute gastroenteritis is acquired via a fecal-oral route, including ingestion of contaminated food or water. Severe cases can result in dehydration and may result in hospitalization. For cases caused by bacterial pathogens, specific antimicrobial therapy may shorten the duration of symptoms and can also clear the organism from the stool and help to prevent further transmission. Although the overall mortality from infectious diseases has declined in recent years, the mortality from acute diarrheal disease actually increased in the years of the survey between 1980 and 2014. This study estimated that there are about 179 million episodes of acute infectious gastroenteritis occurring in the country each year, and they result in about 600,000 hospitalizations. Between 1999 and 2007, the number of deaths from acute gastroenteritis in the U.S. rose from 7,000 to more than 17,000 annually. This was mostly driven by Clostridioides difficile. In this presentation, I'd like you to view acute gastroenteritis through the lens of diagnostic stewardship. Now, diagnostic stewardship is an important concept, but it's also one that's frequently misunderstood. We talk about antimicrobial stewardship, implying conservation of the use of antimicrobial agents to limit resistance. And so many people assume diagnostic stewardship just means conserving the use of diagnostic testing. But while the cost-effective use of lab tests is part of diagnostic stewardship, the term actually encompasses much more than just that. I prefer to think of diagnostic stewardship as the appropriate use of laboratory tests to guide patient management in order to optimize clinical outcomes and limit the spread of antibiotic resistance. This is a useful diagram from Kevin Messakar and his colleagues in Colorado that envisages diagnostic stewardship as using the right test in the right patient at the right time so that patients can receive the right antimicrobials at the right time. So this requires that your diagnostic test be quick, that it be accurate, and that it be applied in the appropriate clinical setting. Now, a major challenge in diagnosing acute gastroenteritis is that it has many causes, and these include bacteria like Salmonella, Shigella, and Campylobacter, viruses like norovirus, and parasites like Cryptosporidium and Cyclospora. What's more, the clinical presentation of acute gastroenteritis tends to be nonspecific, so there's a considerable overlap in the signs and symptoms seen in gastroenteritis caused by different pathogens. These are data from a study in Finland. Patients who had gastroenteritis caused by different bacteria or other pathogens had similar duration of symptoms and similar frequency in different signs and symptoms. So even a very astute clinician finds it difficult or impossible to narrow down the possible causes of acute diarrhea based just on the clinical presentation. And yet, the appropriate treatment of the patient really depends on knowing what the specific cause is. The conventional lab workup for stool in patients with gastroenteritis actually varies from laboratory to laboratory, but it invariably requires multiple media that can be selective or non-selective, combined with oftentimes immunoassays, sometimes molecular assays, and microscopy. In our lab, the conventional workup used to include blood agar, an enteric medium, a selective medium for Salmonella and Shigella, McGonnagle with sorbitol to look specifically for Shiga toxin-producing E. coli 0157H7, a Campylobacter agar, which had to be incubated in a specific microaerobic environment, TCBS, which we only used during the warmer months to detect Vibrios, an immunoassay to look for Shiga toxin, and then concentrates of the stool, which would be examined for ova and parasites. So despite all of these components, traditional diagnosis for gastroenteritis has faced significant challenges. selecting the right test requires a clinical suspicion for a particular pathogen. You have to use specific culture media to isolate different pathogens, and some pathogens don't survive well in transport media that are used to convey the samples to the lab. Culture and identification take a lot of time, so the results are often not available to the clinician for days. Molecular or immunological methods are required to detect toxins like Shiga-like toxins or C. difficile toxins. Shiga toxin-producing E. coli, in fact, are considered a contraindication to antibiotic treatment, which poses a dilemma for clinicians. You have to wait for the result to come back, but the patient may have an acute bacterial infection and warrant treatment. And then viruses and parasites can't be cultured by most clinical labs. So these difficulties were really the impetus for the development of syndromic diagnostic test panels. And these typically use multiplex PCR technology to allow you to rapidly detect multiple potential pathogens from a single clinical sample. There are a number of commercial syndromic panels now available for patients with gastroenteritis as well as other infectious disease syndromes. And these have revolutionized diagnosis for gastroenteritis. Labs can choose from a range of panels, small and large, with different combinations of targets, and choose the panel that best fits their patient population, lab workflow, and budget. A few years ago, we decided to replace our traditional stool workup with a multiplex PCR panel. And we did this at our hospitals at the University of Washington. In order to understand the impact of this change on our results, we performed both methods in parallel for a period of time in order to look at the diagnostic yield. Over this time, traditional testing only detected a specific pathogen in 6% of the cases in which samples were submitted to the lab, compared to 35.5% of samples tested by multiplex PCR. So this was a 500% increase in diagnostic sensitivity, which I think is really profound. We found that using syndromic testing allowed us to detect many mixed infections, which using traditional workup we almost never found. And these mixed infections were observed in particular populations. We saw them in men who have sex with men, in individuals who had returned from recent foreign travel, and also persons experiencing homelessness. And these, of course, are populations that have a higher risk of acquiring fecal-orally transmitted pathogens, either because of sexual practice or the likelihood of ingesting contaminated food or water. There were a few organisms that are missed by the molecular testing that we used, and these were mostly Aeromonas and some Campylobacter species, which weren't on the PCR panel that we used. In addition, we noted that the diagnostic test did not distinguish between pathogenic and non-pathogenic Yersinia enterocolitica strains. So because these couldn't be differentiated, it was possible that we were detecting some non-pathogenic Yersinia. We found that multiplex PCR testing shortened our turnaround time dramatically. It reduced the duration of the analytic phase of testing. Those of you who work in laboratories are used to thinking of pre-analytic, analytic, and post-analytic. And the big impact was on the analytic phase, and this allowed us to better fulfill the goals of diagnostic stewardship. By using a rapid test, we were able to give the clinicians an answer within hours instead of days, which ended up impacting their approach to patients. Even though in our hospital, we only performed the PCR testing during the day and evening shifts, the mean turnaround time was still shortened by more than 2 days. In many cases, we were able to give results to the clinicians while the patients were still present in the emergency room or the clinic. There was initially some concern that PCR, by being more sensitive, might be detecting asymptomatic colonization or patients who had milder illness that didn't require specific treatment. In other words, that we might be overdiagnosing patients. But when we compared the patients who were detected by culture with those who were detected by PCR only, We found there was not much difference between the two groups. The only difference was that the culture-positive patients were more likely to have an elevation in their white blood count. So we think that clinical severity was fairly comparable. We were simply picking up a lot more patients and making a specific diagnosis. Importantly, we saw that giving the results more rapidly changed the behavior of our clinicians, and this was without any specific instruction on our part. Clinicians started to realize that they could get test results back in hours, or at the very least by the end of the day, instead of in days. And so they started withholding empiric antibiotic therapy and preferred to wait until they had a lab result so they could make sure they were giving antibiotics to patients who had a known bacterial infection. And when we compared the prescribing behavior to the previous year, where we were performing a traditional workup, we saw that antibiotic therapy was both more timely and more appropriate. So although the results at our two hospitals were interesting, it was still difficult to say whether they were applicable to other institutions which might have different patient populations. And so to address this question, a large collaborative study was performed with scientists at bioMérieux and the data analysts at Premier PINC AI. I'll tell you a little bit more about Premier in the next slide. But the goal of our study was to harness the power of big data to analyze the epidemiology and the economic burden of acute infectious gastroenteritis in U.S. adult outpatients, and to figure out whether the diagnostic method that laboratories used impacted clinical outcomes and resource use. The Premier Healthcare database was used to analyze adults who had a principal diagnosis of acute infectious gastroenteritis during an outpatient visit. This database contains healthcare data from nearly 1,200 facilities across the U.S., representing approximately 25% of all hospital discharges in the country, over 1.3 billion outpatient encounters. The goal of this retrospective study was to determine the demographic and clinical characteristics, the pathogens detected, and the healthcare resource use in nearly 250,000 U.S. adult outpatients who had acute infectious gastroenteritis. We excluded patients who had recent acute gastroenteritis within 30 days or who were making diagnostic testing visits or surgical visits. In patients who had microbiological data available, which is not all patients in the Premier database, we performed an analysis according to the pathogens detected. And we looked at specific predefined outcomes, healthcare resource utilization, costs for the index visit, and the 30-day follow-up period for the same diagnosis. This represents the largest study of adult outpatients, to my knowledge, with acute infectious gastroenteritis that's ever been performed. This is the age distribution of the patients, which ranged from 18 years of age by definition to over 90 years of age. The mean age was 44.3 years. So among the findings that were more surprising was the 63% predominance of women, which was seen in all age groups and in all geographic regions. A considerable burden of gastroenteritis was found to affect adults of all ages, ethnicities, socioeconomic groups, both with and without baseline medical conditions. There was a mix of payers, including private health insurance, Medicaid, and Medicare, and 13% of the patients were uninsured. Most of the patients were seen in an emergency room setting and were discharged home. About half were seen at small hospitals, and most were seen in urban and non-teaching settings. Only 1% of patients required hospitalization for the same diagnosis within 30 days. Less than 1% underwent ancillary GI or abdominal diagnostic testing, and about 3% required an additional outpatient visit for the same problem. The mean costs for the index case and the 30-day follow-up period ended up being $1,338 per patient, which ended up totaling over $330 million for the entire study population. As not all premier database hospitals report their microdata, 27% ended up having micro results available. Clostridioides difficile and norovirus were the most common pathogens. 47.5% had no pathogens detected, and 4% had more than one pathogen detected. A total of 36,787 patients who underwent diagnostic testing for gastroenteritis were eligible for the part of the study that correlated diagnostic tests with outcomes. So we compared people who had a traditional stool workup, which you can see in beige, with those who had multiplex panels used for their diagnosis. The large panels and the small panels were differentiated. If you had more than 12 targets, that's shown in lavender, and if you had less than 12 targets, that's shown in blue. The mean cost of testing was $153 per patient, and the large multiplex panels, not surprisingly, because they have more targets, were associated with a 62% higher diagnostic yield. But they were also associated with fewer stool tests required per patient because the patients who had a small panel or a traditional workup often had additional tests that were subsequently ordered. And the turnaround time was 4 times more rapid, which again is not very surprising. The average overall healthcare cost for the index visit of the patients who underwent stool testing was $2,485. It's not surprising this is higher because testing tends to be done in the sicker patients. But what was not necessarily predicted was that the overall healthcare cost for index visit plus 30 days follow-up for patients who were tested with the large PCR panels was actually a bit lower than for the traditional workup or for the small multiplex panels. So this is one of the central findings of the study, that the higher cost of the more expensive diagnostic panels could be offset by reductions in follow-up medical costs. In clinical microbiology, we often stress the importance of not thinking about healthcare costs in silos, because sometimes we spend more money in the laboratory in order to save money elsewhere in the system. But actually finding hard data to convince your hospital administrator that this is the case can be challenging. So I believe this study is vitally important because it shows this to be the case for acute infectious gastroenteritis. We used large multiplex PCR panels, which gave us a more rapid and a more accurate result. But people may argue, what is the impact on cost of spending more on diagnosis? And we found that by spending more money up front for diagnosis, that we could save healthcare costs subsequently. So we basically got improved patient care without increasing the overall costs for that diagnosis. In addition, the patients who were tested with the large multiplex panels were more likely to be discharged home. They were less likely to be hospitalized within 30 days for acute gastroenteritis, and they were less likely to receive in-hospital antibiotics, 39% versus 45% for those who were tested with a traditional workup. And this is most likely because the large panels had viral targets, which people had argued, well, you don't really need to know that a norovirus or a sapovirus or an adenovirus is causing your gastroenteritis, but to the clinician, this means they have an explanation and they don't have to use an antibiotic. So the rapid detection of a viral pathogen can be beneficial because then clinicians avoid empirically prescribing antibiotics. This not only saves costs, but it prevents this adverse impact on the patient's microbiome of antibiotic exposure and maybe getting C. difficile down the road. So several findings in this study warrant some specific discussion. Although the reasons for the female predominance in acute gastroenteritis are uncertain, there are some potential explanations. For one, there may be differences in exposure to young children who can be a source of C. difficile and other gastroenteritis pathogens. Dietary preferences are another consideration. There was a big Shiga toxin-producing E. coli outbreak in Germany a number of years ago, and female predominance was found to be attributable to the fact that the food vehicle were fenugreek sprouts at salad bars, and females were more likely than males to eat salad. And then healthcare utilization patterns for a lot of medical problems differ between females and males. Women are more likely to seek medical attention, whereas males often hesitate to seek attention until they're prodded into doing so. That's a generalization, but it's a pattern that is seen in many medical conditions. We also saw that the large PCR panels were more likely to be used for immunocompromised patients, such as those with transplants or HIV/AIDS, and in urban hospitals. And this makes sense because clinicians may be more concerned about these high-risk patients and looking for a broader differential diagnosis. And so the large PCR panel patients were more likely to have these comorbidities. They're sicker patients, and yet the clinical outcomes in many ways were superior. I also want to emphasize that diarrheagenic E. coli was very likely underreported. In our hospital, they're amongst the most common targets that are detected. Enteropathogenic E. coli and enteroaggregated E. coli in particular are very, very common in our population, and I've heard this from other laboratorians around the country. But at the present time, people are a little bit uncertain about the clinical significance of these organisms, because you can asymptomatically carry any enteric pathogen, and in particular, you can find carriage of these E. coli asymptomatically. However, they're very important in the setting of chronic or persistent diarrhea, and we've seen patients who had months of diarrhea associated with EPEC or EAC for whom targeted treatment completely resolved symptoms, and they were mistakenly diagnosed with things like inflammatory bowel disease or sprue. And so it can be very useful to diagnose these organisms in the right clinical setting. And I think because a lot of laboratories are not reporting them, even when they're performing larger panels, and because they're not represented on smaller panels, that they were probably under-detected. And then finally, the patients tested with the large PCR panels, as I mentioned, were less likely to receive in-hospital antibiotics. I want to re-emphasize this point because it's one of the real clinical benefits of using a multiplex PCR testing, that it's achieving the goal of antimicrobial stewardship by avoiding unnecessary use of antibiotics in people who have viral gastroenteritis. So returning now to our patient, to remind you, this was a man experiencing homelessness who presented with 1 week of severe symptoms from shigellosis. What you may not know is his infection occurred in the context of ongoing parallel outbreaks of Shigella infections in Seattle, which incidentally we're still having. And these particularly involve two populations, men who have sex with men and persons experiencing homelessness, although they have spilled over into other populations, for instance, because some people experiencing homelessness were working in restaurants, and then we had restaurant-associated outbreaks as well. In collaboration with the Salapante lab and a study headed by Jonathan Fairley at our institution, a whole genome sequencing analysis was performed and demonstrated that there were discrete clonal groups of multi-drug resistant Shigella flexneri and Shigella sonnei circulating in these populations. And so different patients who had particular epidemiologic risk factors were more likely to carry one or another strain. And we were able to use this knowledge, along with the availability of rapid diagnostic testing, to create treatment pathways based on the most likely susceptibility patterns of the Shigella isolates causing infections in patients who had risk factors of being men who have sex with men or persons experiencing homelessness. Most of the Shigella isolates from the men who have sex with men in Seattle were susceptible to fluoroquinolones, and most of the isolates from persons experiencing homelessness remain susceptible to trimethoprim sulfamethoxazole, but not the other way around. So this knowledge allowed us to achieve about 70% concordance in our empiric therapy, despite the presence of multi-drug resistant strains that had different susceptibility profiles. So even before any susceptibility testing had begun, we could simply say in 1 or 2 hours that this patient was at high risk because of belonging to one or another group. Okay, so going back to the slide, basically we're saying that we know that specific clonal isolates of Shigella are circulating in different populations, and they have discrete susceptibility patterns. And so most of the Shigella isolates from men who have sex with men, as you can see, are susceptible to fluoroquinolones. Most of the isolates from persons experiencing homelessness are susceptible to Septra. And so this allowed us to target therapy based on the group that the patient belonged to and the fact that we knew they had Shigella because of the rapid diagnostics. And so we could achieve about 70% concordance in the study by using this knowledge, even though we were dealing with multi-drug resistant strains, which were not really highly susceptible to any of the commonly used diagnostics. So this is an example of how knowledge of your circulating epidemiology combined with rapid and accurate diagnostics can facilitate antimicrobial stewardship. We were able to target therapy appropriately, and this was particularly important in these patients who are at risk for forward transmission to other individuals, to get them on effective therapy promptly so they would stop shedding. So based on his risk factor of unstable housing and the known susceptibility profile of our outbreak strains, our patient was diagnosed while he was still in the emergency department, and he was given trimethoprim sulfa. His symptoms resolved quickly. His culture subsequently confirmed he had Shigella sonnei that was susceptible to trimethoprim sulfa. So for the time I have remaining, I'd like to make a few additional observations before we open it up for questions regarding acute gastroenteritis in specific populations. So you may recall the age distribution of outpatients in the premier study that I showed you. It was more likely for younger patients to have acute gastroenteritis, but there were still significant numbers of older patients. And these data from our study at the University of Washington Hospital showed a similar distribution of pathogens in older patients compared to the study overall, with the exception that older persons were less likely to have C. difficile. But what's important to recognize is that even though the proportion of older persons reporting typical gastroenteritis symptoms declines with age, their risk of having severe disease and hospitalization goes up. And for that reason, it remains an important population to assess gastroenteritis in. They're more likely to have complications. They're more likely to have dehydration, more likely to require hospitalization. Another special population, as you've gathered, is the men who have sex with men, and they're at increased risk for a broad range of enteric infections with bacteria, viruses, and parasites because of sexual practices involving fecal-oral transmission. It's common for them to have mixed infections, and the circulating strains of Shigella and Campylobacter in this group of people have a higher risk of being multi-drug resistant, perhaps because these patients have a higher frequency of antimicrobial exposure for things like sexually transmitted infections. In this study that I performed with Newman and colleagues at the University of Washington, we looked at the spectrum of pathogens seen in men who have sex with men, and you can see that Campylobacter, diarrheogenic E. coli, Shigella, norovirus, Cryptosporidium, and Giardia were particularly frequent. We also found that it was more common to find resistance to fluoroquinolones in macrolides than in overall Campylobacter and Shigella isolates. And we even saw some Campylobacters that were resistant to both macrolides and fluoroquinolones. And we saw some Shigella isolates also who were resistant to all of the standard oral therapy, which is requiring clinicians to use really uncertain medications to treat these MDR and XDR, Campylobacter and Shigella strains. This is really an emerging and not completely solved problem. Returning travelers are also a high-risk group for gastroenteritis. And this is a study from Bradley Connor that found that 63% of returning travelers had a pathogen detected by PCR. So returning travelers are considered to be an appropriate group for testing with a multiplex panel because they can successfully identify the pathogen in most cases and allow targeted therapy. And when I mentioned that diarrheagenic E. coli is particularly common in travelers' diarrhea, and azithromycin or fluoroquinolone are commonly prescribed, but most laboratories cannot culture and identify enteroaggregated and enterotoxigenic E. coli. And when studies have been done where these isolates have been obtained and tested for susceptibility, travelers have been found to have high rates of harboring azithromycin and fluoroquinolone resistant EAEC, ETEC, or EPEC from Asia, Africa, and Latin America. Rifaximin has remained active against most isolates. Needs more clinical evaluation, but it might be an option for patients who have one of these organisms and no inflammation. And lastly, I'd like to say a little bit about C. difficile. The inclusion of C. difficile in multiplex PCR panels has been controversial. And this is principally because toxigenic C. difficile can be detected in asymptomatic persons, as well as those who have symptomatic infection. And because the clinical settings in which C. difficile infection and acute gastroenteritis from other causes are generally thought to be fairly distinct from those of C. difficile infection. But what I want you to notice is that the incidence of community-associated C. difficile infections appears to be rising even as healthcare-associated C. difficile infections are plateauing or falling in many places. This is most likely because they're really different separate problems, and intensive attention to C. difficile and reducing the risk of acquisition in the hospital is yielding some benefit. But in the outpatient setting, it's been relatively neglected, and the epidemiology is very different. So the patients are distinct from those who are in the inpatient setting, and clinicians may be more likely to overlook them because they lack the conventional profile. These data are from a study in Spain, and they found that community-acquired C. difficile infections are underdiagnosed, often due to a lack of clinical suspicion. When these laboratorians perform toxigenic culture for C. difficile, which is a more sensitive method than a toxin assay, and they did this whether the clinicians asked for it or not, they were able to detect another 13% of cases. And the unsuspected cases they noticed tended to be in younger persons. More than a third of them lacked recent antibiotic exposure. And other studies have also found that persons with community-acquired CDI are more likely to be female. This may be attributable, again, to greater exposure to young children who are not infrequently colonized with toxigenic C. difficile. And multiplex panels that include C. difficile may aid in the detection of these unsuspected cases. At my institution, many outpatients with C. difficile detected have not had any pathogen other than that detected on their panel, and they've been treated for C. difficile and they appear to respond. So my opinion, based on my experience and what I've seen about the rising problem of outpatient C. difficile, is that it's a good idea to include this target on multiplex panels, because otherwise you'll miss these cases. An important caveat, of course, is that asymptomatic carriage of virtually any GI pathogen can be seen. So testing has to be performed in people who meet specific criteria. Since PCR is highly sensitive, it can detect low levels of organisms in asymptomatic carriers. And this was a study performed in adults and children in the Netherlands, and they found that about half of asymptomatic control subjects, so these are people who feel fine or going about their business and have no diarrhea, had a potential pathogen detected by PCR. So institutions should have standard criteria that must be met in order to perform any kind of stool workup. And there are guidelines from the American College of Gastroenterology and from the ID Society of America that suggest testing in individuals who have moderate to severe acute diarrhea, diarrhea lasting a week or longer, dysentery, in other words, fever, bloody, or mucoid diarrhea, and severe cramping, sometimes sepsis, immunocompromised hosts, and in outbreaks involving food handlers, healthcare workers, daycare attendees, or employees and residents of institutions. You don't need to meet all of these criteria. If you meet any of these criteria, then it can be appropriate to undergo diagnostic workup for acute infectious gastroenteritis. So in conclusion, to answer the question that I posed in the title of my webinar, here's what the real-world data are telling us. Acute infectious gastroenteritis is a common and expensive problem for U.S. adults, with a mean cost of $1,338 per episode. Females outnumber males by 1.7 to 1 among U.S. adults with acute gastroenteritis. The cost of large PCR diagnostic panels can be offset by savings and associated healthcare costs, and they provide a higher diagnostic yield, faster turnaround time, and reduced in-hospital antibiotic use. And looking at the big picture, I think this illustrates how large administrative databases can provide novel and important insights into the epidemiology of common illnesses like acute infectious gastroenteritis and the complex impacts of diagnostic testing on the utilization of healthcare resources. Multiplex PCR panels can provide rapid and accurate test results in the appropriate patients who can then receive either targeted therapy or supportive care, thus targeting antibiotic treatment to the patients who are most likely to benefit and limiting unnecessary antibiotic use. And in this way, these tests promote the goals of both diagnostic and antimicrobial stewardship. I'd like to acknowledge the many colleagues at the University of Washington who contributed to this work, and at bioMérieux and Premier. In particular, I want to mention Brie Couturier, who originally conceived the Premier study, and Rena Moon, who was the lead analyst from PINC-AI. And I'll close by adding that the prevention of acute diarrhea is better than the cure. And along those lines, here are a few restaurants you might want to avoid. So with that, I thank you very much for your interest, and I'd be happy to take your questions. Thanks a lot for listening.
Dr. Fang, thank you so very much. That was a wonderful presentation. In the time remaining, let's look at some questions now. As you can all imagine, we've got a great number that have really been intrigued by the notion of diagnostic stewardship, and it's a great concept, and I'd like to know more and hear more. But a lot of the questions quickly began to focus on payment. And so let me give you, Dr. Wang, a couple of these. I realize you're a clinical microbiologist and a professor, not a healthcare economist, but I'm interested in getting your take on these. Is there anything that you can do or an institution can do to encourage a reduction in claims denials by insurers who are doing this frequently for syndromic testing, especially panels with GI pathogens? I'll add to that question one that really rides along with it. Given the clinical benefits of large molecular panels, as you've so well outlined today and shared with us all, how can labs navigate the lack of Medicare reimbursement in the outpatient setting?
So this is a very complicated question that we've been dealing with at my own institutions, as well as hear a lot of colleagues dealing with this across the country. The difficulty is multi-pronged. There were a lot of discussions when these tests first came online with Health and Human Services, and getting Medicare criteria to fit clinical need was the product of a really protracted discussion. And these limited coverage determinations that were put out by the different contractors that cover different regions of the country for Medicare are not exactly identical. And so your particular situation may differ from my situation. But what we've noticed is that by and large, clinicians are adhering to the testing criteria of our institution. And our testing criteria correspond very closely to our region's testing criteria, where Medicare is supposed to cover the cost of these tests. But what's happening is that in the billing process, the clinical indications are not being conveyed. So Medicare has stated in our region that they're willing to pay if patients meet certain criteria, if the test is ordered by an ID or GI specialist, or if they meet certain clinical criteria, like the patient is immunocompromised, they've been sick for 7 or more days, they have severe or moderate diarrhea or dysentery. And you'll notice that these criteria correspond to exactly what I told you are our institutional criteria. So we're finding that patients are being tested appropriately in many cases, and they're being denied because the codes do not convey the information that the patients meet these criteria. And these denied payments may potentially be appealed, but this is very laborious for billing to do, and they have to look at how many denials they're getting and how much the reimbursement is to know whether or not it's worth their time. And I think in the end, the most reasonable solution is going to be if there can be billing codes that are created which actually convey the information that the patient met one of these criteria. If there's a specific code that can be submitted in the request for payment that conveys the information that the patient had severe diarrhea or prolonged diarrhea, meaning a week or longer, or had dysentery or was immunocompromised with diarrhea, then I think the billing would be much more straightforward. So the problem is complicated. It's not actually at this point convincing Medicare that the testing is reasonable. It's figuring out how to actually negotiate the billing system in order to convey this information to the third-party payer so that the test will be paid for. The other thing that is frustrating is that I've shown you that using these more complex diagnostic tests actually end up improving the quality of care and saving costs so that the net cost of care is not affected. And so what we're trying to do here is actually improve outcomes for the patient without increasing costs, and yet we're being thwarted by this system that we work in. And so I know this should be solvable, but unfortunately, it's not really possible to solve it just in the lab or just at the institution. I think there's going to have to be a more systemic discussion about how to make sure that the patients who are undergoing appropriate testing are receiving reimbursement for that. Of course, at your institution, it may also be the case that some inappropriate testing is being done, and then it may be a solution through something like the electronic health record to make sure that clinicians can only order the test in appropriate settings.
Thank you very much. You're certainly right. This is a complicated question. I'm curious, at the University of Washington, have you or colleagues or other people in the department had any luck with your billing folks to add these kinds of patient criteria, at least as notes, to the billing of the patients?
Unfortunately, I don't have anything really to offer here right now. I'd say we're having ongoing discussions about this, about how to allow more information to be conveyed, but we're running up against staffing issues on the side of billing that I'm sure everybody is also having at their institution. Yes. And so I'm not sure what the ultimate outcome of these talks is going to be.
Yes. Well, certainly at a minimum, everyone seems to be very well aware of the problem. I mean, the studies that you've presented today, your real-world data, I think would be a very powerful tool in the hands of those who want to improve the reimbursement for better clinical care. And I think there's a lot of actors that we can look at to help in that, including our associations. bioMérieux itself can be pretty formidable in putting these things together. So we'll stay tuned on that. And I'll go on now with a couple of more clinical questions. The following one, as you might imagine, we're going to hear about C. difficile. Should an ED multiplex GI panel include C. difficile PCR testing? And if yes, should this be backed up with EIA GDH and or EIA toxin testing?
So I do recommend that a multiplex panel include C. difficile testing, and I discussed a little bit of why I think that's the case. because you're looking for C. difficile in a different clinical context. The disease tends to be milder, more likely to be in women. They tend to be younger. About a third of them don't have any recent healthcare exposure or antibiotic exposure. And so the clinical suspicion is often low and the treatment is effective. And so I think it would be good to be able to make that diagnosis. And I don't think you can justify omitting it when C. difficile is actually the most common target detected both in our hospitals and in the real world study, right up there with diarrheagenic E. coli and norovirus. I'm of the opinion that EIAs for either for GDH or toxin testing do not add substantially. I know that a lot of hospitals are using two-step algorithms where they're performing PCR and then they're coupling that with a toxin assay. The reason that I don't recommend that is because a lot of data show that the presence or absence of detectable toxin by EIA cannot distinguish colonization from infection. Patients can have positive toxin assays and be asymptomatically colonized. Patients can have significant CDI, even life-threatening CDI, and have negative EIAs. So it comes down to a clinical assessment, not a diagnostic test to make that distinction. I believe the reason most hospitals using two-step algorithms are doing so is because the NHSN reporting criteria, the Health Safety Network, has been based on the lab diagnosis. And if you perform a toxin assay, you end up reporting a lower number of C. difficile cases. But recent studies, including a study that will be coming out soon in ITCHE, a multi-center study, are showing consistently that about 3/4 of patients who have so-called discordant results, PCR positive, EIA negative results, are actually judged by clinicians to have CDI and they're being treated. And the CDC recognizes this, and they're in the process now of validating new criteria which couple diagnosis with the administration of a C. difficile antibiotic. So people who think that they're gaming the system by using two-step testing and then quietly treating the people who are toxin negative are not going to be able to benefit from this anymore. And it's really going to change the calculation. And I think it comes back to assessing whether the patient is likely to benefit from C. difficile therapy, and it will return the focus where it should always have been on trying to reduce the actual burden of C. difficile, not just the reported burden of C. difficile. So I think for that, it really goes back to making a good clinical assessment, finding out if toxigenic C. diff is present, and performing aggressive infection control to prevent intra-institutional transmission of C. difficile. And I don't find any real utility for the EIA testing. The GDH also, incidentally, is less sensitive than the PCR, and it's not specific because even non-toxigenic C. difficile can be detected by the GDH assay. So I don't think either of those tests are really necessary. I realize there are other opinions on this.
Very good. An excellent answer. You provided some very elegant criteria, and are those adopted as a policy now in the University of Washington hospitals?
Yeah,
for running these tests?
They're in the test guide, and they're distributed to the clinicians. They're in the database of guidelines for the institutional guidelines, and we're constantly trying to reinforce this with our clinicians. At the moment, we don't have a hard stop in the electronic health record if people want to order it, but we're actually thinking about that sort of thing if we find evidence that people are ignoring the criteria. But for the most part, we've seen that people are aware. Part of the reason is not just to limit testing. If you look at people who have acute enteritis, the diseases are largely self-limiting. And even for bacterial enteritis, the symptoms of shigellosis and salmonellosis will often resolve in a few days. In those patients, adding an antibiotic on top of that actually doesn't make them get better any faster. It's only the subset of have prolonged symptoms that benefit. So we're trying to limit testing to the patients who are most likely to clinically benefit. And I think it's in their interest as well as in the institution's interest to test according to these criteria.
Thank you very much. And I'm sure once we have the slides and audio back posted at CAP Today online in about a week, everyone I would recommend should review those criteria and hear more about them. Let me ask you one final question, again, around this question of testing and restrictions. We'll let one example stand for several that people have raised. Could you just speak a little more about the types of restrictions you have for ordering the GI PCR assay on the inpatient side and how you handle overrides? Is there any ban on the GI PCR panel after 3 days of hospitalization?
So that's an excellent question. And actually, the results have varied at different institutions. At the University of Florida, Kenneth Rand and colleagues have found that there's a significant yield for GI panels on inpatients, and it often affects infection control measures. So they would find patients who were under stool precautions who had no pathogens, and they would find other patients who had important pathogens who were not on precautions. And we've had outbreaks of norovirus in our hospital, as I'm sure others have had, where diagnostic testing has been very useful. So I think if you have a suspected outbreak setting, the GI panel can be very useful in terms of guiding infection control measures. But that said, there have also been studies such as from Stanford, which show that the yield beyond 3 days is pretty low, as it has been for the conventional workup. And so a lot of patients who have diarrhea in the inpatient setting are really served quite adequately by C. difficile testing and as a targeted test and not having to have a multiplex panel. So we discourage the use of the panel in inpatients, but we don't absolutely forbid it because of these settings in which it's been useful. Some of the pathogens like the diarrheogenic E. coli and the parasites also, they don't necessarily present with acute diarrhea on presentation, but sometimes they become more evident after the patient's been in the hospital for a few days. So unfortunately, it's not as simple and clear cut, although in general, I'd say the yield goes down in inpatients.
Thank you. Thank you very much. And with that answer, I will give you the last word on today's webinar. I know this is just opening up a world as there'll be a lot more to listen to and read about as we move forward. And so, Dr. Fang, I want to begin by congratulating you and thanking you for a wonderful presentation today. I'd also like to thank, of course, bioMérieux for their sponsorship of today's very important webinar. So I'd like to take this opportunity to thank all of you for joining us today. I know your days in the laboratory are very busy, and I appreciate it, and I'm gratified that you find these webinars to be useful to you. I'm always glad to hear from you with your remarks. And so with that, let me just quickly wind up one more time. I'd like to thank Dr. Ferric Fang of the University of Washington for a great presentation. I'd like to thank bioMérieux, and I'd like to thank all of you who've joined us today. And with that, I'll bring today's webinar to a close.